Hello, I'd like to present a case illustrating the danger of using technetium-labeled MDP to exclude the ATTR form of cardiac amyloid. What is cardiac amyloid? There are two forms. First is the primary form, where an unstable carrier protein, transthyretin, which usually carries thyroxine, gets deposited as amyloid fibrils in the heart, causing a restrictive cardiomyopathy. There are two types, one the wild type, previously called senile cardiac amyloid, and the second inherited as an autosomal dominant trait. The secondary form arises from misfolded immunoglobulin light chains from abnormal plasma cells. Amyloidosis affects many organs that can give us clues, including deposition in the hand causing carpal tunnel syndrome, in the spine causing spinal canal stenosis and back pain, in the bicipital tendon causing rupture, deposition at the shoulder and the hips causing pain, deposition in the tendons causing trigger finger. It can also result in polyneuropathy, resulting in painful hands and feet, muscle weakness, and can also result in autonomic dysfunction, leading to orthostatic hypotension, diarrhea, and erectile dysfunction. Why is it important to make an early and accurate diagnosis? With the advent of new medications such as tafamidis, patient survival is significantly improved by commencing drugs early than not commencing the patient on the appropriate medication. Where does scintigraphy sit in the diagnostic algorithm? It sits just after cardiac PET, but before cardiac MR, echocardiography, or even the development of symptoms. Therefore, it can accurately make a diagnosis early, enabling the early initiation of life-saving therapy. In addition, scintigraphy is far more safer than myocardial biopsy. It is cheaper, more easily performed, and is simple to do. In a study first presented in Circulation in 2016 involving 1,217 patients suspected of cardiac amyloid using tracers such as DPD, unavailable in Australia, PYP, and HMDP, it was noted that in the absence of monoclonal protein, the specificity and positive predictive value for the ATTR form of cardiac amyloid in patients with grade 2 or 3 cardiac uptake approached 100%. I will now proceed to the case study. An 82-year-old man with a past history of prostate malignancy presented to his cardiologist with increasing shortness of breath. His clinical examination was noted to be normal and the patient was found to be normotensive. His ECG was unremarkable and showed no signs of left ventricular hypertrophy. His echocardiogram demonstrated septal hypertrophy, which you can see here, and it spared the apex. The strain pattern demonstrated normal strain involving the apex, impaired strain affecting the rest of the heart. This apical sparing is pathognomonic of cardiac amyloid. His bone scan done as part of staging for prostate carcinoma demonstrated significant degenerative arthropathy affecting the right shoulder, the left knee, and the left ankle. No abnormal uptake to suggest osteoblastic metastases. And in the blown up section of the thorax, you can see very faint uptake, which was concluded by the other institution as not demonstrating the evidence of cardiac amyloid. He was referred by his cardiologist to us after discussion. A pyrophosphate study was performed, which clearly showed abnormal uptake of tracer within the myocardium of the left ventricle as well as the right ventricle on the early 1R images, and the uptake ratio of the heart to the contralateral lung of greater than 1.5 and hence was abnormal. On 3R imaging, which is also mandatory, you can see that the deposition is involving the left ventricular myocardium and is not blood pool activity, and the uptake is actually greater than the ribs at grade 3, and if it was the same as ribs, it would be termed as grade 2. Therefore, cardiac amyloidosis, the ATTR variant, can be diagnosed when all criteria are met. 1. Grade 2 or 3 pyrophosphate uptake, absence of clonal plasma cell process, and typical cardiac imaging features. And in this instance, this was illustrated by the transthoracic echocardiogram, but may also be seen on cardiac MR or cardiac PET. Using the correct tracer, the correct protocol, an accurate diagnosis can be made all the time. Using an incorrect protocol and the incorrect tracer can lead to misreading results. If ever you are asked to perform a test to make or exclude a diagnosis of the ATTR form, make sure you have acquainted yourself with the American Society of Nuclear Cardiology guidelines on how to perform such a test. Thank you.